Hi, my name is Chad Bouterse. I'm an ophthalmologist at Care Specialists in Clarkston, Washington, and today I'm going to share with you my standard technique for implanting the Visian ICL. First, we start off by making a small paracentesis. This, of course, is after the patient's already been sterilely prepped and draped and some topical marking was given for surface anesthesia. Next, some preservative-free and sulfite-free lidocaine is instilled in the anterior chamber. If you are a cataract surgeon also, like myself, you want to avoid putting any kind of epinephrine or phenylephrine in the eye, as later on you're going to need to constrict the pupil, and that causes some problems later on in the procedure. Next, you want to instill some OxyCoat into the anterior chamber. The Visian ICL is only compatible with OxyCoat. The other viscoelastics can cause deposits on the lens, so OxyCoat is the viscoelastic of choice. Just a small amount here to firm up the eye to make my main incision easier to perform. And here we're using a 2.4 blade to make a tunneled incision. You can use any blade you want. 2.4 happens to be what we have already in the OR. To implant the lens, you need somewhere around a 3.5 millimeter incision. So here you'll see me instill a little bit more OxyCoat. You want to be real careful with these eyes since they are phakic to not touch the lens at all. As a result, deepen in the chamber a little here, and you're going to see me drag my wound just a little bit to increase it to a 3.5 millimeter range. At this point, tension's turned off the table where the ICL is checked out of the vial and folded into the plunger-style injector. You can see here that there's a small piece of instrument wipe soaked in BSS. I found this to be the biggest help during the procedure, is to keep the cornea nice and moist. Dry eye is the #1 cause of blur in the first 24 hours with these patients, actually the first week with these patients. So next you can see the plunger-style injector is put into the wound and very slowly advanced. This lens does want to stick to itself and not unroll very easily, so you want to use a gentle tapping motion with your thumb on the plunger of the injector as you're tapping the lens out into the anterior chamber. As the heat of the aqueous starts to work on the lens, it does become a little more pliable and will start to unfold. You can see the superior haptic here has already unfolded. The inferior haptic is sticking to itself a little bit. These are loaded just like interocular lenses with viscoelastics, so they sometimes are a little stubborn. Just a little gentle nudging, and eventually you'll see the haptic fold over here. You can rotate the injector as you need to keep the lens in the proper position, and you can see next to the optic there are some guide holes to help you determine where the middle of the lens is when it is completely rolled up. Next, a little bit more OxyCoat on the surface of the ICL to help push it down away from the endothelium. Again, in this procedure, since the patient is phakic, you want to be very careful of the lens, and you also want to be very careful of not damaging the endothelium, as these are generally very young patients who are going to need their corneas for a long time. Next, this is an IOL manipulator specifically for the ICL. You want to take and tuck the haptics underneath the iris. The eye is still filled with viscoelastics, so it can be sometimes a couple of tries to get the haptic underneath the iris edge. This motion is a more horizontal back and forth movement, not an anterior posterior pushing. You definitely don't want to push down on the lens, as that can cause local cataract formation. Here you can see I've got the two haptics tucked, and then go through the main incision to tuck the two haptics on the other side. You don't want to ever cross over the center of the lens, as you might put pressure down on the optic and again cause local cataract formation. This lens is great for people with mild to severe myopia. It comes in powers of -3 to -20, and that is a spherical equivalent. So people who have very high myopia and are not candidates for LASIK are great candidates for this lens. It's also a great procedure for people who don't want to spend the extreme amount of money to get their own excimer laser, and as a result you can do this with a standard cataract set and a few instruments like that IOL manipulator. So next I'm just rinsing out a little bit of the OcuCoat with some dilute myostat. You don't need a lot of myostat. In my experience I diluted 0.1 to 0.9 of BSS in the syringe, and as you rinse out the OcuCoat you'll start to see that you're going to get the pupil coming down to cover up the ICL. This procedure is very nice in the fact that it is completely reversible. You can take the lens out if there were any complications, which are very rare. It also does not mess with the patient's corneal topography, so later on when they're going to go and get their cataracts removed later on in life, there's no problems with their calculations, and you can be very accurate in getting them right on the money for distance vision. Here you can see the pupils come down nicely once a little more of the OcuCoat was burped out and the myostat had a chance to work on the pupil. And next, just a little bit of rinsing to make sure all the OcuCoat is completely removed and there's not going to be any early pressure spike. You can see here that there is no PI. Visian ICL company recommends that a PI is done a few weeks prior to the procedure. We found that to be uncomfortable for the patient, and as a result we do a PI at a YAG immediately following the procedure while the patient is still numb. The patients are then checked 2 to 4 hours later, the following day and 1 week later, to assure that the ICL is lined up and that the PI is patent. As I do with all my intraocular procedures, just drop a dilute betadine there on the ocular surface to prevent infection and remove the speculum, and we're done. Patient sits up and has fantastic vision. Hope you enjoyed this video. Thank you.